All right. Today, our group is going to be talking about improving interdisciplinary communication for TBI patients. Traditionally, when I get a consult for a traumatic brain injury patient, it's different than a stroke or a dementia case. And it allows me to do fuller assessment and to communicate more information to the team members. The reason that I can do a fuller assessment is because typically speech is intact and the TBI patients are able to do physically a bit more than a stroke. So it allows me to do an assessment to give a true baseline of how they are doing cognitively. And the way I do that is through the Wechsler Adult Scale of Intelligence, the abbreviated version. And that allows me to figure out a IQ that is about both fluid and crystallized intelligence. Crystallized intelligence is the amount of information or data that we pick up over our lifetime. And as we age well into our late adulthood, crystallized intelligence increases. It's the one cognitive ability that actually increases over time. The good news is that crystallized intelligence is very robust against a traumatic brain injury. So when I do my testing and I come up with an age and a education-based normative data, I then can say that that is their baseline. And we'll contrast that with the fluid intelligence, which is the ability to take the data from crystallized and be able to manipulate them. And that's where we get judgment, reasoning, and abstraction, safety concerns. And so we can then compare the crystallized versus the fluid. Fluid is probably the largest cognitive deficit associated with traumatic brain injuries. So as we do that, we're able to both get a pre-morbid as well as a current idea of where they are cognitively. In addition to that, get information from PT, OT, speech therapy about how they're doing, what their deficits are. And that would be a sort of ecological validity to my testing. So I have construct validity with my testing, and I have ecological validity with what's going on in the therapy world. And that allows me also to communicate to the patient's family, caregivers, what needs they are going to have, but also allows us to sort of work with any troublesome, difficult, challenging behaviors that they're going to experience both in the hospital setting and possibly in outpatient. And then I confer with my colleagues in speech therapy.
So we do a lot of interdisciplinary communication with neuropsychology in terms of getting their feedback and their input in terms of a patient's baseline deficit. So, a lot of times when we're getting patients who have a TBI, a lot of the times the patients are coming in with comorbid pre-existing conditions. Like a lot of our patients come in with a baseline diagnosis of dementia, or maybe Parkinson's or metabolic encephalopathy, and that comes with its own baseline difficulty. So we really rely on talking with the neuropsychology team to determine if the patient's deficits are baseline, if these cognitive deficits that they're experiencing now are new, if they're exacerbated. And sometimes it could be a combination of both. And I think the big thing to remember is that when our patients are coming in, they're coming into the emergency room, then likely to the ICU, then to a step-down unit, and then to us on rehab. So by the time they get to us on rehab, a lot of the times they don't remember 50 to 75% of their hospital course or even the reason why they're admitted. So when they're coming to us in rehab, we're giving them this information. They're almost seeing like they're hearing it for the first time. We're telling them this is what you have to work on, this is why. These are the things that have changed with your status. These are the new things that are going on. And it can be very overwhelming for a lot of our patients to hear this information. So with that, and with patients with these cognitive deficits, sometimes it results in increased frustration. You might start seeing the patient refusing whether it be therapies or maybe nursing care, refusing medication or attempting to stand up, be a little bit more impulsive because their insight into their deficits is decreased. So we do try to all, talk with each other on the unit because we do have a lot of different activities and supports that we can provide to the patients on the unit to help them in terms of their rehab stay, increase their participation, and kind of increase their overall success. And you're obviously going to talk about some of the interventions that we have on the unit that can be helpful.
So a big part of our focus is to make sure every patient is safe with reducing any injuries, the potential for falls, as well as making sure that they're comfortable in their environment. A lot of times when we see restlessness, agitated behaviors, patients trying to change, get out of the chair, that's probably due to some underlying cause. So we always want to try to identify that root cause. And those root causes can be something as simple as maybe they need to use the restroom. Maybe unfortunately, they had an accident, their clothes are soiled. The chair they're sitting in is not the most comfortable. The environment they're in is not conducive to their needs. They may be fatigued and it might be too bright. Or on the other hand, they might be ready to get the day started or do some more activities during the day and the room is too dark. So we want to try to look at those things and from there plan accordingly and adjust whatever may be needed. An example with toileting is trying to set up with nursing staff the time toileting schedule. This way it allows the patients to make sure that they are on the toilet schedule so they're not feeling any urgencies midway through the day, through their therapy sessions, or even in the evenings for that matter. Some other areas that we could look at considerations are trying to change the environment. If it might be too dark or too dim, we want to look at the possibilities to adjust lighting. Sometimes the roommates' television may be too loud and they may want to switch that. So we want to look at being able to maybe provide the roommate with headphones. Something also important is to be able to engage the patients in activities that are meaningful to them. We've had situations where people might be very physically active throughout the day in their careers and moving around. Now they're confined to sitting in a wheelchair and just looking at the wall. So that's not what they're used to, but maybe getting them involved with some activities such as some of the games we have here. Connect Four, using some playing cards. There's a busy apron here also, which has got some opportunities for some sensory stimulation. The soft touches can provide some calming effects, as well as these terry cloth towels, folding towels, or even trying to identify what they may have been doing in the past. We had a patient who was a bookkeeper and was very agitated, restless, always seeking attention. And we were able to find that out that she was a bookkeeper. So we'd given her a journal as well as some sheets of paper with some formulas and numbers, and she was able to enter those journals. And her demeanor totally changed from needing the attention, being redirected to being focused and calm, focusing on the task, because it gave her a sense of normalcy of what she was to do day to day. Any strategies that we come across, we try to share with each other. So using the iPads is pretty important. So this way there's some consistency on something that we may find helpful, and then we can pass that on to the next caregiver or therapist or nurse or PCT who may be providing the care.